Now we are joined by Salimata Samake. She is the coordinator for health and nutrition for Action Against Hunger, and she will be presenting from the abstract number 113, if you'd like to go check it out, scaling up severe acute malnutrition treatment through community health workers in Mali. So over to you, Salimata. Salimata, are you with us?
Oui, je suis.
Wonderful.
Yes, I am here. Okay, thank you. Many thanks to all. We are delighted to take part in this meeting. My name is Salimata Samake. I'm Health and Nutrition Coordinator for Action Against Hunger in Mali. This is a quick overview of our experience in the management of severe acute malnutrition through community health workers. In 2014, there was an increase in the prevalence of acute severe malnutrition with a high rate of loss to follow-up. There was a sort of blanket coverage for moderate acute malnutrition. 3.6% was much too far from the norm recommended by WHO of 23 health workers. Sometimes it's difficult to manage severe acute malnutrition depending on the program and the strategy for essential care. ACF, Action Against Hunger, in cooperation with the MOH, decided to evaluate the impact of ICCM for SAM without complications. SAM is severe acute malnutrition, through operational research. SAM without complication was not in the healthcare package. The study took place in two phases. First, 2014-16, we can reach a good quality of care. The lady is speaking very fast, says the interpreter. Very, very fast. We were able to increase the blanket coverage. We doubled it compared with baseline. And the study helped us to demonstrate that the intervention was definitely beneficial for the recipients. And the cost was reasonable. But the first phase was, cost us a lot for supervision. It was difficult to roll it out on a bigger scale in the state, given that the state is already, or the government is already struggling with health problems. So the second part of the study focused on supervising the supervision in 3 different districts. In Bafoussam, the control district, we had standard supervision for treatment as described in the handbook without the support from the health authorities. Previous slide, please. Thank you. So the area of intervention number 2 case, ACF was financing this intervention, and in the 3rd district, Kita district, the model was the one supported by ACF, but also we had additional supervision that was nutrition specific. So in the second phase, you see the results here. In intervention zones 1 and 2, we reached our performance indicators with monthly supervision with a good rate of people being cured. However, in the 3rd zone, where there was monthly supervision but without any external support, we didn't reach the target. You see the dropout rate, loss to follow-up is very high, and the number of people cured is much lower than in zones 1 and 2, Kaita and Case. There was less intense supervision, but external support. Where supervision was intense, you know, routine supervision plus nutrition-specific supervision or monitoring, the coverage was kept stable. What explained the stable coverage in Kita was that we didn't have any other program supporting this community activity, which was screening and referrals, whereas in Case they had projects dealing with those activities. Next slide. So in conclusion, we've seen that ASC provide a good quality treatment that is comparable to the one given by health centers, ASC being community health workers. Well, here there is a mistake on the slide. It's a monthly supervision. That's what we recommended, this intermediate model, which can promote the scaling up. This type of supervision is cheaper and is more efficient than the other model. And to increase the coverage, we've seen it was necessary to keep screening at the community level, even though it's integrated in the healthcare package of the ICCM, but we have to continue pushing community screening and try not to have too much overlapping between health facilities. So we were able to integrate the management of SAM in the healthcare package. It's fully integrated. Thank you for your attention. I believe I stuck to my 5-minute time allotted to me.
It was wonderful. I would like to remind the audience that they can ask questions of the various presenters and on the various issues and themes that we're touching upon, and we can get to those as possible. Salimata, I would like to sort of take this opportunity to ask you one or two follow-up questions. First, a question that I think is very important for all of us is, how did the referral system work? So referring to a higher level of care, whether it's hospitalization. The question is, what was the referral system like? So referring children from a RECO to a hospital or a health
Thank
center.
you for that question. Can I answer? Yes, please. Go ahead. So about referral to a higher level of care, it took place as follows. At the level of the villages, the community liaisons, what we call the relays, would do the screening and refer the children to the sites where there were some community health workers. Then the child was tested again by the community health workers. All the parameters were checked to know whether the child needed management at a higher care level. After examination by the community health worker, if a child has to go to the upper community level health facility, it's the community health worker that would make the arrangements with the parents of the child to arrange, for example, for transportation. If there are any complications, we had the same system in place, referral by community health workers after being screened. by the liaison, and we give a lump sum for transportation based on the distance when the mother has to bring the child to the URENI level. The referral framework locally, malnourished children are not integrated in that system, in that loop. They take charge of obstetric emergencies, that's all. But we are advocating for malnourished children with complications may integrate the system so we can call an ambulance, just like we do with any other emergency, to try and save those children and have them hospitalized. So that's the referral system we have locally.
Thank you so much. And we have a question from the audience. And if this is not your area of expertise, feel free to pass on it. But what is your opinion of adding treatment for neonatal sepsis to the ICCM package? And if that's, again, not your area of expertise, we can move on to another question. And we can save that for someone later in the panel.
Well, I think... What?
Oui.
The sound is stopped? Oh, in the healthcare package, yes. Concerning Mali, what they say in the handbook is that community health workers can take care of neonate care, but only the cord care, no more than the cord care. So they provide cord care, and community health workers also follow the breathing rate, heart rate, and if there is any danger sign, they're not authorized to provide more care. They have to refer the child.
Okay, thank you. And the last question, and this is also coming from the audience, is how did the COVID pandemic affect the ICCM Plus, and what did you do to adapt to the situation?
Okay, merci. Au niveau du Mali, au début
Thank you for the question. In Mali, at the beginning of the pandemic, it was panic at the very beginning. Everybody was in a panic. And at that time, SESCOM, all the referral health centers, health facilities were deserted. People would no longer go to health centers. And even the mothers at the community level wouldn't be screened by our community liaisons. They were afraid of being in contact with other people. And that highlighted the importance of community health workers in treating both infants and women. So where we work, we've seen that we had more admissions in our own health posts than in health centers. There are small health posts in a small village, few people coming at once. They feel at home, they're not afraid. But if you ask them to go further to a bigger health center, they would be afraid of being contaminated. So they stop going to normal size healthcare centers. And that's what urged us to do this research on the management of malnutrition with a simplified protocol because there is an emergency. So we do more studies now on a simplified protocol for malnutrition management, better adapted to the emergency context.
Another incredibly important pediatric health issue. Tanya Morshed is the Mental Health Activity Manager for Médecins Sans Frontières Holland, or OCA, Operational Center Amsterdam. And she will be giving an oral presentation from her abstract number 94 for those following at home. a description of the family DOT model of care for drug-resistant tuberculosis in pediatric patients in Tajikistan. So Tanya, over to you.
Great, thank you very much. We really appreciate the opportunity to share a little bit about our family direct observation therapy model of care. Next slide, please. We started our pediatric drug resistant tuberculosis program in 2011 here in Dushanbe, Central Asia and Tajikistan. And we started it with the direct observation therapy program. We saw about an 85% treatment success rate, which is pretty good. But then we also added the FDOT, the Family Directed Observation Therapy Program, in 2017. And what we've seen is a 98% success rate, which is why we really wanted to take this opportunity to share a little bit about it. Next slide, please. So what is the Family Direct Observation Therapy Program, the FDOT program? It is a home-based program where we have a comprehensive care team going out and providing support for the families. Now, this is a pediatric program, so we really need to include the families. And this requires the nurse, the doctor who is managing the treatment of course, of the medications and side effects. We also have a counselor who manages things like adherence problems, health education, and also caregiver support. And we have a social worker who helps connect patients and families to resources in the community and addressing issues such as economic barriers and food. So this is really important to have this holistic care for our families, the pediatric families. In addition to that, we've seen that this program, because it is home-based, is really adaptable. So during COVID, we were able to adapt this program and reduce the number of home visits to once a month and deliver medication once a month, and then support remotely. So we had our whole team calling our patients and caregivers and following up and seeing how they're doing. And what we saw is that there weren't any disruptions in treatment, which really made a big difference. This also because they didn't have to go to health facilities and be exposed to COVID. So this really was a big deal for us that we were able to really continue to support our families during COVID through this model of care. Now, the other thing is that the clinical relationship is quite important. So as I mentioned, we are going and providing home visits. Normally, we go twice a month or more, depending on the situation, and then we do phone calls in between. This kind of constant support really helps the families feel at ease and trust us. So that trust really is crucial, especially for the caregiver when they're feeling any anxiety or having any questions or any concerns about the treatment. Now, speaking about the caregiver, we can go to the next slide, please. We really take some time to select the caregiver who is going to really follow and monitor the medication management of our patient. So they are really, we take the time to assess their, how well they understand everything, how reliable they are, and how they understand the importance of treatment completion, and that they have a positive relationship with the child. They're also given tools like pill boxes and medication management charts, and of course our phone numbers to call us at any time. So this makes a big difference for pediatric patients to complete their treatment. The other factor that really helps is that we try to address the barriers. As I mentioned, we also have counselors and social workers. You know, it is really difficult for some of our families to go to the health facilities because of long distances or not having enough money for transportation. They may have multiple children, and taking them to health facilities can be very difficult and disrupt their family responsibilities. There may also be multiple family members who have tuberculosis, and trying to manage all of those appointments can be very challenging. So being able to go to the home really helps reduce some of these barriers for our patients and supports that treatment completion. We do include the MOH staff, so we do take MOH nurses and doctors with us to make these home visits. So the MOH staff are also learning from us and are also developing the relationships with the patients. And so when the patients are going for their monthly investigations or testing, then there is a connection to them, and that really builds that trust and continuation. So let's see here. If you could go to the next slide, please. Thank you. So we've seen that the 98% success rate continues throughout, whether it's a male or female, the different types of drug resistant tuberculosis, and age. Okay, great. And what you see is a picture of our positive reinforcement charts that we use for the children. So this is important to mention because we do try to develop a relationship with the children and empower them to be a part of their treatment plan as much as possible, especially if they're older or are teenagers. Then we want them to really take some ownership and do as much as possible so then they can feel the success of completing their treatment and getting better. So this is how we are trying to be developmentally conscientious and include them. We also try to provide some developmental stimulation because, pediatric tuberculosis requires long treatment, and especially if they have to be hospitalized, they can cause some developmental delays. So our counselors also provide some developmental stimulation. Thank you. Next slide, please. All right. So we do provide some satisfaction surveys just to get an idea of the impact of this program. So in the beginning of treatment, we provide a survey, and the end of treatment. And what we have seen is that the caregivers and or even the teen patients who are able to give us some feedback are really grateful for being able to be at home and not having to go to health facilities, especially if they're concerned about stigma. Going to the TB dispensary, in and of itself will disclose that they have tuberculosis, and that's very difficult for a lot of our patients in this context. It also reduces some of the challenges that our caregivers has, as I mentioned before, in regards to managing all of the care needs. And this all makes a really big difference. Next slide, please. So this is just our questionnaires, the pre and post. So you can look at that in closer detail at another time if you would like. Next slide, please. So this is the initial survey shows a 14.95 satisfaction rate out of 15, and then the final survey is 18.85. So one thing is that we realized that the final survey needed a little bit of an adjustment because some of the questions were a little bit difficult for our patients to understand and caregivers. So we did shift some of the wording and languaging. And even though that is the case, the 18.85 is a pretty good score. And some of the feedback that they've shared is that, they really are grateful because it was difficult for them to visit the DOT centers prior to the FDOT, and they were able to really continue their treatment and complete it because of some of the barriers. So, and would like for MSF to increase the FDOT program to all of the tuberculosis patients that are in Tajikistan. So we've got some pretty good feedback about that. Next slide, please. All right. So what does that say and what does all this mean? It really just means that, especially with pediatric tuberculosis program, we really need to include the family, and we really need to adapt it to be developmentally and culturally appropriate. In Tajikistan, it is a very family-centered culture. So we find that this program really respects that and includes them, and this makes a big difference. And lastly, we really believe that empowering the children and families to take ownership and accountability for their treatment really also makes a big difference in treatment completion and support. So I think that's it for now. If anyone has any questions, I'm happy to answer. Thank you very much for your attention.
Thank you so much, Tanya. Yes, there are actually a whole bunch of very, very specific questions about the details of the program. So it's a wonderful one. And what we're going to do is use the networking lounge. If people could use the networking lounge, and we'll try to group the relevant questions by panelists. And maybe you can join the networking lounge at another point to start answering them. But I do have one question for you.
Yes,
so
please.
Do you have any key messages for other projects around the world working with pediatric patients in chronic disease programs, not necessarily just TB? Do you have any messages for them?
Yes, that's a great question. Thank you. I think a lot of the key success factors in this program can be extrapolated to a lot of the other pediatric programs. You know, children are not in silo, so you really do need to include their caregivers and families. So whoever that guardian may be, whether it's a parent or a grandparent or uncle or even a community member that is trusted, that relationship to that child is really important, especially when it comes to long-term treatment. So then they can really be motivating and encouraging for the child to continue, because the side effects, especially for tuberculosis, can be quite difficult to cope with. So we really need to have this caregiver really involved and really encouraged and empowered. So really, I think that's key. The other one is having providing holistic care, a comprehensive team. Not all of our MSF programs have counselors and social workers, and I think that this really makes a difference, especially in a pediatric population, to have the holistic care. So I suggest, if you don't have other support staff in addition to nurses and doctors, to please consider that. Of course, I'm a bit biased. I'm a mental health activity manager, but it's because I think it is, of course, very crucial, and it's good to see that MSF is actually expanding a lot more programs to include that. And then I think that really trying to provide this home-based treatments as much as possible, it makes a big difference too. If kids can go back to attending school as soon as possible and socialize and receive the developmental stimulation that they need to feel normal and to develop as their peers, this really also can be motivating and helps them heal and recover faster. So these are some of the recommendations I have. Thank you.
Great. Thank you very much, Tanya.